What actually makes UTI complicated? The new classification depends on two clinical questions. One, does the patient have systemic symptoms, especially fever, rigor, flank pain? Two, is there a catheter in place? Transurethral, suprapubic, or intermittent catheterization make UTI complicated. For empiric antibiotic selection, four steps approach save a life. First step, assess severity of illness. The patient in sepsis or not. In sepsis, early appropriate therapy saves life. In non-septic patient, mortality is low. So, sepsis determine your initial aggressiveness. Second step, assess patient-specific risk factors for resistant organisms. The patient had a previous culture with resistant pathogen. The time frame for comparing cultures varied, but the median was 3 to 6 months. Ask the patient about previous antibiotics that administered. Avoid fluoroquinolones if the patient has been exposed to it in the past 12 months. Third step, the third step, consider patient-specific factors, allergies, contraindications, drug-drug interactions. Step 4, use antibiogram. In septic shock, select antibiotic with 90% susceptibility for the relevant organism. Sepsis without shock, select antibiotic with 80% susceptibility is acceptable. What is empiric therapy recommendation? In sepsis with or without shock, preferred third or fourth generation cephalosporins, carbapenems, piperacillin tazobactam, fluoroquinolones. Alternative, we can use novel beta-lactam, beta-lactamase inhibitors, cefadrochol, or older aminoglycoside. Without sepsis, IV antibiotic preferred third or fourth generation cephalosporins, piperacillin tazobactam, or fluoroquinolones. Alternative, carbapenems, newer agent, beta-lactam, beta-lactamase inhibitor, cefadrochol, or older aminoglycoside. Without sepsis, oral antibiotics, fluoroquinolones, or trimethoprim sulfamethoxazole, alternative amoxicillin clavulanate, or oral cephalosporins. When can you switch from IV to oral antibiotics? As soon as the patient is clinically improving, can take oral medication, has an effective oral option available. How long the patient should take antibiotics? For clinically improving patient, 5 to 7 days of fluoroquinolones, 7 days for non-fluoroquinolones. In critically ill patients with severe sepsis, immunocompromised, urinary obstruction, those patients we need individualization.